All right, so the last one of the skeletal system here before we kind of take a look at some of the actual bony landmarks and bones and a few other things like that. So last thing to really kind of get into is how the skeletal system regulates bone, really bone growth. What is influencing when bone is being deposited, when it's being reabsorbed. So really get into how do we regulate our bones. Again, excuse me, we need a number of nutrients, things like calcium, things like different phosphates. We need these in our diet. We need things like vitamin C and A and K and some of these other vitamins as well. But one of the things that's interesting is calcium and phosphate especially, you need the hormone calcitriol to be present. And what's interesting on this one is calcitriol, one of the things required to synthesize this is a steroid called cholecalciferol. That is also known as vitamin D. So vitamin D is necessary to take in calcium and phosphates from your diet. We get this, as we were saying in the last chapter, through sunlight on our skin. One of the things that if you're deficient in, the bone health might be suffer somewhat. But that's one of the things we do definitely need is this cholecalciferol in order to make calcitriol. The other things that we're going to have definitely other hormonal influences. So things like growth hormone, that leads to growth of a number of different things, increases in muscle development as well. But it is going to play a role in these bones when the epiphyseal plates are present. Thyroxine also stimulates just normal base metabolic rate. Both of these things in higher levels are going to stimulate bone growth. Again, especially prior to puberty and prior to those growth plates closing. Different glucocorticoids, so some of the steroid hormones from the adrenal cortex are involved in blood glucose levels. High amounts of these can lead to bone loss and impaired bone growth. The other thing we're going to see is different sex hormones. So estrogen and testosterone, both during puberty, start to be secreted at much higher levels. These increase cartilage growth as well as bone growth at the epiphyseal plate. But overall, over time, these are through that puberty are going to close that growth plate because they stimulate the bone formation a little bit more than they stimulate the cartilage growth. And so eventually all that's going to seal that plate and the bones will stop increasing in length. What's kind of interesting on this one, estrogens especially are much more stimulatory of osteoblast activity, and this is part of the reasons even if male and a female both at puberty, started puberty, let's say on the same day, generally the female is going to have the growth spurt first just because estrogens are a little bit more stimulatory of these osteoblasts. The other thing that's going to play a large role in the bones is really the body's needs for calcium. So calcium or blood calcium levels are a very important homeostatic mechanism that's involved with mainly the skeletal system. Calcium is important for a number of different things, releasing neurotransmitters. It's a big part of normal heart function, having enough calcium. It is required for muscle contraction to take place. It's required for blood clotting to take place. So having the correct level of blood calcium is very important. And because the bones store 99% of the body's calcium, it's not surprising that the skeletal system is going to play a role in regulating these blood calcium levels. We're going to see that there's really two main hormones. When we get to AMP2, we will kind of re-hit on this again a little bit. These are part of the endocrine system, but we have two main hormones as well as there's going to see kind of a third one as well that are going to regulate blood calcium levels. So calcitriol, we already mentioning, is the hormone that allows you to take in calcium and phosphates from your diet. We're also going to talk about a hormone made by the parathyroid gland, which they very originally named parathyroid hormone. So the important thing here is vitamin D is necessary, so that cholecalciferol or vitamin D is necessary to synthesize calcitriol. So generally UV light hitting the skin is going to convert a precursor molecule into vitamin D3, which is cholecalciferol. Again, we can take this in from our diet as well. This circulates through the body, is converted by liver enzymes, and this is kind of happening continuously in the body. What's going to happen is that calcidiol that was converted to in the liver is going to be converted to calcitriol by the kidney, and that becomes the active form of that calcitriol or vitamin D. One of the things that we're going to see is parathyroid hormone increases. So increased levels of parathyroid hormone will increase the speed of this step and cause more calcitriol to be formed when we have more parathyroid hormone. And that calcitriol is going to stimulate absorption of calcium and phosphates from the intestines into the body. So parathyroid hormone, like I said, is made by the parathyroid gland. It is 4 little small dots on the back of the thyroid, which should be right about here. It is going to act on, and not surprisingly, if we think about this, we know we had a few different bone cells. We knew osteoblasts. Those are the bone-making cells. What are you going to need to make bone, though? We know calcium salts are very important in bone, so if you're going to make more bone, what are you going to need to get into that bone to make it normal bone? You need calcium. Because of that, when you have osteoblasts being active, that is going to take calcium from the blood and put it into the bones. Osteoclasts, on the other hand, digest bone or break bone down. If there's calcium stored away in those bones and those osteoclasts dissolve that bone and reabsorb it, it's going to make more calcium available to the bloodstream. So, not surprisingly, parathyroid hormone is going to play a role on influencing these osteoblasts and osteoclasts. So, parathyroid hormone is going to be released when blood calcium levels get too low, so to increase blood calcium levels. Going by that case, we know that we should not, if we want blood calcium levels to go up, we shouldn't be stimulating osteoblasts. We should stimulate the osteoclasts. So parathyroid hormone binds to osteoblasts and inhibits their activity. And it's also going to cause those osteoblasts to secrete a factor known as osteoclast stimulating factor, which is going to increase that reabsorption of bone. Inhibiting osteoblasts, stimulating osteoclasts is going to increase the release of calcium from bones. That would be one thing that would bring up blood calcium levels. Parathyroid hormone, as we already were saying, is going to stimulate the kidneys to convert more of that calcidiol to calcitriol. More calcitriol means more absorption of calcium from the digestive tract. And the third thing, not surprisingly, if we kind of go through these so far, we're taking calcium out of the warehouse. We're bringing more calcium into the body. The third one that would make sense is don't lose any calcium from the body if we need to keep those calcium levels high. So parathyroid hormone also is going to inhibit the kidneys from excreting calcium ions in the urine. So kind of a three-pronged approach here. Again, blood calcium levels are too low. Parathyroid hormone release, it's going to take more from the warehouse over here. So inhibit osteoblasts, stimulate osteoclasts, more bone reabsorption, more blood calcium. More calcitriol synthesis, more intestinal calcium coming in, increase blood calcium levels. And then finally, don't excrete calcium ions, which is going to help maintain higher blood calcium levels. There is another hormone. Its role is maybe not quite as significant as parathyroid hormone or calcitriol, and this is something called calcitonin. So the way to think of this one is calcitonin tones down blood calcium. This is one that can be released by the thyroid gland, by something called C cells in the thyroid gland, and this is in response to higher blood calcium levels. What it does is it's going to act on the osteoclast. So again, if this is blood calcium levels too high, we don't want to reabsorb bone, so we're going to inhibit osteoclasts and then stimulate osteoblasts to be more active. This is also going to let the kidneys excrete more calcium into the urines, reducing these blood calcium levels. Again, the role in this is not quite as well understood, partly because, and we'll see on the next slide here in a second, I'll show it there, but over incredibly high, like pathologic and high levels of calcitonin don't necessarily dysregulate calcium homeostasis, but I'll show you that in a second. So again, calcitonin tones this down, so it's going to decrease osteoclast activity, stimulate osteoblast activity, and let the kidneys excrete more calcium ions. So you can kind of see here, working the opposite on those bone cells. And these are, again, really straightforward kind of essay questions that I can ask that would really get into, do you understand what's going on here? Why would we want to stimulate osteoclasts and inhibit osteoblasts in one case? Why would we want to do the opposite in another? Understanding how these are going to help maintain that blood calcium level is, to me, kind of one of the key ideas in this chapter. So this one, again, the full role of it is not 100% understood. Again, calcitonin is much more effective when children are growing. If they've done a couple of different things when they try to actually inject this, it cannot bring about a long-term decrease in blood calcium levels. And absence of calcitonin or really high levels of calcitonin do not tend to dysregulate blood calcium levels. So its role is not fully understood on this, for the very simple fact that if we knew exactly what it's doing and you had really high pathologic levels of this and it dropped blood calcium levels really low, that would make sense. The fact that it doesn't do that, for some reason we can see that calcitriol and parathyroid hormone obviously have greater effects on this than calcitonin does. And really kind of one of the last things to talk about, just one of these things that we see every so often with elderly populations, kind of one of these conditions that can happen with bone reabsorption and bone deposition. Osteoporosis is what happens a lot of times when bones are reabsorbed much more so than they are getting bone deposition, and what it leads to is bones being really more porous and really less dense, and this makes them much more prone to fractures. This tends to be more common in elderly women than elderly men, and this does make sense in the sense that testosterone levels throughout life are going to decline, but they don't completely go away. Women, once they go through menopause, do not have a monthly cycle, and they're not going to get that monthly blast of estrogen, which would stimulate osteoblast activity. That goes away. Because of that, anytime the body needs to reabsorb some bone for calcium, it's going to be done, but you're not getting that monthly hit of estrogen to stimulate bone deposition. So that is why we see this a little bit more often, well, definitely more often in females than males. And just the last couple of things here are just kind of showing some of these other ones here. We talked a little bit about if we didn't have the right amounts of kind of the organics versus the inorganics in the bones, that you can get bones that are either very fragile. I'm trying to think of the word I wanted to use, but either that or you get bones that are somewhat bendy. Rickets is the example where you have populations in certain areas of the world that sometimes have issues with getting enough vitamin D. If you don't have enough calcium due to a vitamin D deficiency, you are not going to be able to bring in enough calcium. No vitamin D, not enough calcium, it's going to lead to bones that do not have that hardness to them. And what you can see here is you end up with bones that are capable of getting a little bit more bendy. They don't support weight as well. Paget's disease is another one here where it's this kind of excessive bone breakdown, reabsorption, put it back, and again can lead to spotty weakenings of the bone because you're continually depositing the bone, reabsorbing it, depositing it, and you get much more spongy bone than you should have and less compact bone, and it leads to decreases in strength. Another issue you can have is vitamin D deficiencies can lead to scurvy. Scurvy is, people with scurvy, if you remember Pirates, you scurvy dog type of thing. Scurvy is a lack of vitamin C. Vitamin C is necessary to make collagen fibers, and if you're very vitamin C deficient, you can lead to bones that are much more brittle, and that's the word I was looking for. And things like teeth falling out, other stuff like that with that absence of vitamin C. This was a big thing early in history with when different countries started having their navies sail around the world in different places. A lot of times you'd have not a lot of vitamin C on these boats. That's where pirates, always being on a boat, lack of vitamin C. And that's actually also why the British Navy has the nickname limeys because they used to bring limes on the boats for vitamin C. And this is just kind of talking a bit more about Paget's.